And thank you very much for coming to listen to me this afternoon. And right from the beginning, I should explain to you that my talk is a fraud, because there actually isn't a psychiatry of posterior cortical atrophy yet. And so I'm going to talk a little bit about the psychiatry of conditions that are a bit like PCA and what we do know about PCA. But I'm also going to take the opportunity to explain to you a few things, and at the end, I'm going to be asking you for your help to help people like Seb and myself to establish a psychiatry of PCA over the next few years. So I was taught that when you gave a lecture, it was always very important to detail your objectives at the beginning, because then everybody with a short attention span could fall asleep after seeing the first slide, but could talk intelligently later about what had been in the talk just because they'd heard the objectives. So I'm going to begin by explaining what a psychiatrist is and what we do, because you'd be amazed how many people find it quite hard to define a psychiatrist. I'm always being asked, what's the difference between a psychiatrist and a psychologist? And when you tell people you're a psychiatrist, they will often ask you that question, or they'll go very quiet, and they'll say, "Oh, isn't that a bit like saying you work for the Inland Revenue?" As a conversation stopper. I then want to talk a little bit about why we know so little about the psychiatry of PCA. Then I want to tell you about some of the treatments that we use with similar conditions. And then finally, to think about future directions. And again, something that you as an association, I think, could be very helpful with. I mean, you must represent the largest group in the world of people with PCA and people who are connected to people with PCA. You're an extraordinary resource. So, what are psychiatrists and what do they do? So, everybody has their own, perhaps prejudice is the wrong word, their own preconceptions of what psychiatrists are. As a psychiatrist, I've never asked a patient if their mother had big thighs. I was also a bit disappointed when I came into psychiatry to discover that we don't show patients ink blots and ask them. I felt a bit cheated that sort of mysterious thing had disappeared from practice. But this is what we are. We are medical doctors, just like GPs and neurologists and gastroenterologists and cardiologists. What's different from us is we've completed postgraduate specialist training in psychiatry. So we've done between 6 and 8 years of extra training specialising in psychiatry. And we are members or fellows of the Royal College of Psychiatrists. What that means is we've followed a course of study set out by our professional organisation, the Royal College of Psychiatrists, and we've taken a tough exam to become members of the Royal College of Psychiatrists. And when we've got rather old, so that we can pay bigger fees to the Royal College of Psychiatrists, we're given the honour of becoming fellows of the college. Now, I'm not a fellow of the college, I'm a member of the college. And when people ask me, well, why don't you go for the fellowship? I say, because I think it's a sort of vanity tax. Why would I want to pay an extra £400 a year to call myself a fellow of the college? I'm a member of the college, and that's an honour that I earned by passing an exam. Now, we've also, psychiatrists who are consultants who finish their training will have completed specialist higher training in one of 6 different psychiatric subspecialties. So every psychiatrist will be a particular kind of psychiatrist. So I'm an old age psychiatrist, I'll explain later what that means. But we also have adult psychiatrists. It doesn't mean that they're over 18, that means they look after people of sort of working age. Child and adolescent psychiatrists, and again that's obvious what they do. Forensic psychiatrists, they look after people with mental health problems who've got into trouble with the law. Medical psychotherapists, those might be the kind of psychiatrists who would ask if your mother had big thighs. They follow the more kind of traditional psychotherapy role. Learning disability, again looking after people who've got various some intellectual disabilities, and old age psychiatry. We always come at the end as old age psychiatrists of any list. And at conferences, we're always asked to present after everybody else because nobody's really very interested in older people, as many of you will have discovered. So that's what we do. Now, psychiatrists tend to work within mental health NHS trusts. Again, from the outside, it must seem a bit mysterious that mental health is organised within different trusts from acute hospitals. So I'm a professor at UCL, but I also work 1 day a week as an old age psychiatrist with the community mental health team in Camden, and I work for the Camden and Islington Mental Health Trust as part of that. So even though I spend a lot of time in UCL and UCLH, I only have a very special honorary contract with UCLH. So I'm not part of that sort of medical trust. And the only reason that I have that honorary contract is that was the price I had to pay to get a swipe card to let me into the Dementia Research Centre in Queen's Square. But I've only ever been into UCLH to use the canteen. And so psychiatrists get a bit anxious in acute hospitals. We don't really like to see blood and sort of distressing physical illnesses. And most of you will have had dealings, my guess is, with neurologists rather than psychiatrists. Now, if you were looking after somebody or if you had Alzheimer's disease, the chances are the specialist doctor you would see wouldn't be a neurologist. It would be an old age psychiatrist like myself. So probably about 95% of people with dementia in the UK who see a specialist doctor will see a psychiatrist rather than a neurologist. Obviously something very special about Queen's Square and the service that's run here. And people often say, well, what is that? Why are we seeing a psychiatrist rather than a neurologist? Or what separates out the patients who see one rather than another? It's very, very difficult to explain that because often it depends on just what the local setup is. But I can tell you how psychiatrists are different from neurologists. We're very different from neurologists. So even though we have the same basic medical qualification and we will often look after almost exactly the same patients, we are different in our approach. And I think my observations, since I moved to UCL in June, I spent quite a lot of time working with neurologists. And my observations are there are two main differences between myself and my neurology colleagues. The first is that psychiatrists are very happy to tolerate uncertainty about what's causing the diseases we look after. So if you're a neurologist, but this is my psychiatrist's prejudice, if you're a neurologist, you like to think that the disease that you're looking after is real, by which you mean there's something in the brain that you can see on a scanner or that you can elicit through your examination and testing that explains why the patient has the problems that you're seeing. So that's one difference between neurologists and psychiatrists. The second difference is a more subtle one, and that's that psychiatrists really expect to get patients better. So neurologists are quite used to dealing with disorders that they can't really change. They can diagnose them, they can explain what's happening, but they're quite tolerant of being able to just accept that there's nothing really they can do other than just be very nice to the patients and watch the inevitable unfold. And whereas psychiatrists, we are much more optimistic and we're much more interested in intervening with patients. That's largely because most of the illnesses that we see, we do believe we can get better. Most people with psychiatric disorders, mental health diagnoses, get a lot better with the treatments that we offer. So the photograph that you can see at the bottom, that's a picture of the previous president of the Royal College of Psychiatrists, Dame Sue Bailey. And you might not be able to read the slide, but I'll read it to you. What she is saying in the slide is, as psychiatrists, we straddle a unique blend of science and humanity. Bridging the social, medical and neurosciences, we strive to improve the mental health of individuals, families and societies and provide strong leadership throughout the care pathway. So that's quite a grandiose sort of claim, isn't it? But actually it's quite nice to be part of a profession that has those sort of lofty ambitions. So that's what psychiatrists do. Now, I told you that I'm an old age psychiatrist, and this is the kind of work that old age psychiatrists do. So broadly, we provide diagnosis and treatment for people over the age of 65 with mental health difficulties. And we also look after younger people who've developed dementia, or young people with dementia who've got sort of complex physical healthcare needs. And the reasoning is that, look, if we're quite good at looking after old people with dementia, we're probably quite good at looking after young people, particularly if they've got complicated physical care needs. And about half of the patients that an old age psychiatrist looks after have one of the dementias, and about half have what we call functional disorders. And by that we mean disorders that aren't like dementia, where we can't explain what's going on in the brains of patients that underpins their symptoms. And that means things like mood and anxiety disorders, psychosis, personality disorders, very controversial diagnosis, but I'll tell you, when you meet a patient with a personality disorder, you realise it's more than someone who's just a bit horrid. These are illnesses, and we recognise them, and we provide assessment and treatment for patients. And substance misuse, so people with alcohol and drugs problems. And as an old age psychiatrist, most of the substance misuse problems that I deal with are actually patients who've become hooked on sleeping tablets and medications that they've been given by doctors rather than things they've gone out and bought from drug dealers. And old age psychiatrists, there's a number of places where you can find us. We have specific habitats where you can find us. So we work in community mental health teams, as I do, in Camden. So we work in large teams with people, most of whom are nurses, but where we have social workers, occupational therapists, physiotherapists, speech and language therapists, and psychologists who make up our colleagues. And we work in a very different way, I think, from other doctors, in that we truly work as part of a multidisciplinary team. And we're not the boss in that team. It's very, very interesting. We have a clear responsibility and set of roles as senior doctors. So, for example, we're probably the members of the team who are most confident about making diagnoses, but we're not necessarily the best at assessing suicide risk or someone's care needs. Hospital-based units, so lots of old people with mental health problems who need to be admitted to hospital. Psychiatric hospitals have wards which are specifically set up for older people. And then finally, memory services. So I spoke before about how probably 90% of people with dementia in the UK will get a diagnosis from an old age psychiatrist. So we are located in memory services. So old age psychiatrists work again as part of multidisciplinary teams in memory services. And that's a huge part of what we do as the Department of Health try very hard to make sure that as many people as possible get a good quality early diagnosis for their dementia. So I really don't want to talk at length about the diagnoses we look after, but I want to just basically skate across a couple of them. So mood disorders, so everyone is familiar, everyone will know someone with depression, and not everyone will know someone who's got bipolar disorder, where as well as being depressed, they also have periods when their mood is elevated and high. And you'll again, you might not be able to read it, but on the right-hand side is a picture of Robin Williams, and it's a sort of quite poignant, given what happens to Robin Williams. And it's a quote from him. It says, "Do I perform sometimes in a manic style? Yes. Am I manic all the time? No. Do I get sad? Oh yes. Does it hit me hard? Oh yes." So mood disorders are, very life-threatening, very dangerous, horrible illnesses that cause massive morbidity and mortality. The good news is they're really amenable to treatment. So, we have excellent antidepressants and mood-stabilizing drugs and access to psychological treatments that make a huge difference to people with depression. Actually, it's a very rewarding diagnosis to treat. Now, psychosis is a very misunderstood kind of area of medicine. But I guess the important thing to understand is that in psychosis, patients lose touch with reality. And as part of that, they experience delusions and hallucinations. And very helpfully, this is a sort of chart I downloaded from the internet, this table here. And it tells you what delusions and hallucinations are. So just listen carefully to what a delusion is. So delusions are fixed, false beliefs that cannot be corrected by logic and that are not consistent with the culture and education of the patient. So they're just impossible false ideas. But again, you have to imagine how difficult it would be to be living with somebody who had a fixed and false belief that no amount of logic or explanation would shift. Exhausting, as well as, very, very difficult and frightening for them. Now, hallucinations, and again, it's really important to get the definition of hallucination right. Hallucinations are false sensory perceptions experienced without a real external stimulus. So they're a percept without a stimulus. And the reason that's important to understand is that when a patient is having a hallucination, as far as they're concerned, it's a completely real experience. It's not a as-if experience. The patient's not saying, it's as if there's a voice in my head. the patient is saying, there is a voice, I can hear it in the room, it's a real voice, and don't try and tell me it's a hallucination, doctor, because it's real. It's not in my head, it's a real thing. And then finally, illusions. So illusions are not symptoms of psychosis. Illusions are things that we all suffer from. We all experience illusions. We all think, as we're walking home this time of the year when it's dark, as we go home from work, and we think, good heavens, there's a crouching man in the garden of my neighbour. I wonder if he's going to mug me. And as we get close up, we realise, it's just a hedge. Okay, that's an illusion. And we're all subject to illusions. Very different from the hallucination. If I actually saw a crouching man, and as I got closer, it became clearer and clearer that, gosh, there really is a crouching man there, but I got my wife out and she said, there's nothing there, you're just seeing things, that would be a hallucination. Now, the point about these sort of symptoms is they're not like the symptoms that other doctors deal with. So diabetes is defined as having a blood sugar level above a certain degree. A neurologist will diagnose that someone's had a stroke by tapping out reflexes and measuring the strength in the limb and perhaps looking at a scan and actually sort of seeing where the lesion is that's caused it. So when I, as a psychiatrist, am examining a patient and I think, gosh, he's telling me about this problem and it's a delusion, I'm using my own judgment about what's reality and what isn't, and I'm applying that against the patient's reality. And then this little cartoon down the bottom, I don't know if you can see it, where there's a psychiatrist talking to a patient and he's saying, on the other hand, there's always a possibility that you really are Napoleon and I'm just some nut who thinks he's a psychiatrist. So there's something about that subjectivity of what we do as psychiatrists and constantly placing our own experiences and our own mental state against that of the patient that we're examining that is quite unique and different, I think, from other branches of medicine. But I mentioned, I think, that an important part of what we do is diagnosis and treatment in dementia. So I know that neurologists do diagnosis too, but old age psychiatrists, we are the kings of dementia diagnosis, just because we see so much of it. And at the moment, the Department of Health has a target. They would like to see 75% of people with dementia getting a good quality diagnosis very early on. So in most PCTs are running at about 60%, but the ambition is to get that even higher. And as you'll probably know, there's some debate about, well, what's the value of that? What's the value of making a diagnosis of dementia early? And I think probably the main argument is that it's to get people onto the Alzheimer's disease drugs. So the cholinesterase inhibitors and memantine, which I'm going to talk about in a moment. I know you heard this morning, didn't you, about those drugs. I'm going to tell you a little bit about them too, how a psychiatrist views them. But also, I think having a diagnosis is so important if you're going to support and inform families about what's happening to them at the moment and what will happen and how they can be best prepared to deal with it. But then finally, to diagnose and treat the complications of dementia. Remember, I told you that as psychiatrists, we're very optimistic about finding things that we can treat and get better. So there are lots of complications of dementia that we can actually make better. Now, I started my talk by explaining that this is a fraud, that the Psychiatry of PCA doesn't really exist. And I mean, I'm afraid it is true to say that very, very few PCA patients are seen by psychiatrists. And here's a real confession. I have never seen a patient with PCA in my work as a psychiatrist. Never. And I don't think I'm unusual. I can remember reading about PCA and scratching my head and thinking, does this really exist? When Terry Pratchett had his diagnosis, I was a bit sceptical. And I thought, well, this is just something dreamed up by some clever neurologist. He's probably just fine and a bit anxious and neurotic. But then I met Terry Pratchett and it was clear that he had Alzheimer's disease, actually. So I think that's the first thing to say. No one knows much about the psychiatry of PCA because not many psychiatrists have seen patients with PCA. But there are a small number of case series that have been published, and actually most of the literature about this comes from Seb Crutch and his colleagues here. And it's very difficult to be sure what a case series is telling you as opposed to a proper sort of retrospective kind of systematic study. But I think there is a suggestion that visual hallucinations and problems with visual perception and generalized anxiety may be more common in PCA than in patients with Alzheimer's disease. Maybe. And actually, if you look at the literature, and you realise how little we know, the conclusion I come to is that we need to do a study. We need to do a proper prospective study. We need to actually follow patients and their families and chart the symptoms that come as they come. And that needs to be done by people who are skilled and expert at diagnosing and eliciting psychopathology. But we know a lot about the psychiatry of Alzheimer's disease. And PCA, as I understand it, has a lot in common with Alzheimer's disease, with some features of Alzheimer's disease. Or perhaps I should say, some patients with PCA have a lot in common with some features of Alzheimer's disease. And the kind of delusions, remember we discussed what delusions are, that are seen in Alzheimer's disease. There's no point in me just giving you a lecture about those, but if we look at the two most commonly used instruments that are used to collect evidence of delusions in Alzheimer's disease. So they're an instrument called the Behave AD and another one called the NPI, the Neuropsychiatric Inventory. They classify delusions under a number of headings. It's worth just going through these because these are exactly the kind of problems that people with Alzheimer's disease and their families have to deal with because they're delusions. So first of all, if we look on the left, people are stealing things. This is the commonest delusion in Alzheimer's disease. And there are a number of reasons why this comes about. The most prosaic is a patient forgets that they've put their bus pass underneath the phone book, can't find their bus pass, thinks that someone must have pinched it. Thinks, well, who has actually come to my house who might have pinched it? My daughter comes every day. Therefore, my daughter has stolen my bus pass. And when she comes, I'm going to bend her ear until she gives it back. Your house is not your home. So again, patients have problems recognizing their environment and recognizing the sort of familiar cues that would show them this is in fact their home. They lose that ability and they find themselves in a foreign, strange place that definitely isn't their home. I guess the closest I can imagine this is like is if you've ever been jet-lagged somewhere the other side of the world and you've woken up in the middle of the night in a strange hotel and for a few moments you thought, where on earth am I? And you've thought, perhaps I'm at home, and you've tried to reconstruct your bedroom in a strange hotel room just for a few seconds as you're waking. That kind of perplexity in trying to sort of put cues together to work out where you are. Then a terrible delusion, the delusion that your spouse is an imposter. Terrible for you, but awful for them. Awful for them. So a failure to recognise people who are actually close to you as being those people. Delusions of abandonment, delusions that all your family are abandoning you and aren't going to look after you and care for you, and you think you may have heard them talking about putting you in a care home, and you can't see that's because your behaviour is perhaps putting you at terrible risk, and actually putting you in a care home would be a really nice, safe thing to do. You just see that as evidence that you've been abandoned and betrayed by your family. Infidelity, anxiety that your husband, a conviction that your husband is having an affair with the nice nurse who comes 3 times a week supposedly to check on you, but really she's coming because she's having sex with your husband upstairs in the bedroom. Again, terribly difficult area to deal with. And then you'll see general suspiciousness and paranoia and other delusions. And then the NPI, the Neuropsychiatric Inventory, has overlapping but slightly different delusions. So that others are planning to harm you. So you overheard your son and daughter talking about a lasting power of attorney perhaps, or wondering about your will, and you knew what that meant was they were planning to do something terrible to you and take all your money. The idea of people stealing from you, infidelity, unwelcome guests. So if you've lost the ability perhaps to recognise yourself, many patients will say, there's a strange, ugly old lady who lives in the hallway. Well, the hallway is the only room in the house that has a mirror. And the poor patient has identified their own reflection as someone they just don't recognise. And again, you'll see house not your home, abandonment. And then amazing that people on the TV and in magazines are real people. And they've actually come to visit you, and your memory is that Trevor McDonald actually comes to your house at 10 o'clock at night, and you have conversations with him and whatever. And again, it's very, very difficult because it's a delusion. It's absolutely fixed, and one can't be argued out of it. Now, as psychiatrists, as I've explained to you, we like to treat things and make them better. And you'll probably be aware that there's been a huge, in the last sort of 15 or 16 years, there's been a huge push to provide treatments for behavioural problems, whatever that might mean, in dementia. And I guess the symptoms that have been treated have often not been very specific. And what that's meant is there have been lots of studies looking at agitation, which is really a cluster of symptoms, a sort of constellation of symptoms, or also treating a total score on one of those scales, like the Behave AD or the NPI. So rather than, as we do in other bits of medicine, saying the blood sugar is high, let's give a treatment against the blood sugar. Or the patient's got a delusion, let's give an antipsychotic to treat the delusion. There's been a tendency to say the behaviour is difficult, let's lump it all together and let's give a drug that will make the behaviour a bit better. And the drugs that had the sort of prime place in this search were the atypical antipsychotics, so drugs that were developed to treat patients with schizophrenia. So it seemed like, certainly 20 years ago, we thought that those drugs were much kinder to patients than the more traditional antipsychotics that have been used to treat schizophrenia. And so if they were kinder and easier to take, then it made sense that they could be given to fragile older people and would be easier for them to take. So lots of drug companies did large pivotal trials where they looked at the effects of treating with these antipsychotics versus giving a placebo drug to see if they could improve difficult to manage behaviours. And I show you this slide because it shows you something of the difficulties that the drug companies and those of us who want to develop treatments have. So I'm sorry if this is difficult to see. I hadn't realised we'd have such a small TV screen to look at, but let me just talk you through. If you look at so there are two graphs here in one. Look at the graph on the left. Now going along the x-axis, now I know you're a very clever North London audience, so I could talk about x-axis and y-axis. Going along the top is time in weeks. And if you can't read, because it's so tiny, at the end is 12 weeks, so about 3 months. And going down on the y-axis is the score on one of these scales that measures difficult behaviours in dementia. And essentially, going down is a good thing. It means that your difficult behaviours are becoming less troublesome. Now, you may not be able to see, but on that slide on the left, there are actually 3 lines, and each of those indicates a limb in a clinical trial. So there are 3 limbs here. One is patients who are randomised to get placebo. One is patients who are randomised to get risperidone, which is the new, safer antipsychotic. And the other limb is patients who are randomised to get haloperidol, which is an old antipsychotic that it's like a pantomime villain. Everybody hisses when it comes on because it's known to cause horrible side effects and make people very stiff. So what you're seeing on that slide is 3 groups of people, and they all are getting a bit better, aren't they, as time goes on. And I remember showing this slide to in my daughter's school. Oops. Well, I made it bigger. That might help a bit. But I remember showing this slide at my daughter's school when they have one of those days when parents go in and talk about what they do. And I showed this slide to a class of 12-year-olds, and I said, "What does this slide tell you?" And a very clever 12-year-old, not my daughter, of course, said, "Placebo is a really good treatment for these behaviours." And of course, that's I wonder what button I pressed that made that happen. But of course, that's a really tough thing for drug companies, isn't it? Because for them to show that their drug works, they have to show it's better than placebo. So in a situation like this where there's a big placebo effect, it's a real challenge to show that your drug offers any more than that. And because we live in an era of evidence-based medicine, doctors like myself, we don't like to give out treatments that are just placebos. Despite the fact that for about 5,000 years, doctors like myself have made a very respectable living out of the placebo effect. We'd like to think that there's more to it than that, and we want to show that what we do is better than placebo. So you can see something of the problems people have when they're trying to develop treatments for this indication. And you can also see that sometimes these behaviours, they just get better if you do nothing or if you give some kind of placebo intervention. Now, it's really important to remember that. because I think sometimes we think we're very powerful and we can change things, but actually sometimes just by doing nothing or giving a sugar pill, you can change things too. Now, I became very interested in this area because I didn't like to think of people with dementia being given antipsychotics when they shouldn't be, because as you'll know, they're dangerous drugs for people with dementia. They give them strokes and kill them, which isn't really a good thing. So I became very interested about 10 years ago because there was a lot of hope that maybe the dementia drugs, that's drugs like the cholinesterase inhibitors like donepezil, or also drugs like memantine, might actually be good treatments for those difficult to manage behaviours. And lots of doctors would tell you, oh yes, I find it with my patients, they're very, very agitated, sometimes a bit psychotic and hallucinating. I start them on donepezil and it's wonderful, all those symptoms disappear. So we did a big trial, and the slide on the left shows you two groups of patients, one who was randomised in a double-blind fashion to get donepezil, and the other that was randomised to get placebo. And we looked at their agitation inventory score over 12 weeks, and these were all patients who were very, very agitated, who normally would have been given a drug like risperidone, the antipsychotic, and what we found was there was no difference between drug and placebo. Absolutely nothing. I can remember when the statistician showed me the results, and I'd spent 5 or 6 years of my life working on this, I was gutted, because no one wants to do a study that has a negative result. But actually it was really important and useful to know that the drugs don't work. And memantine, the slide on the right shows that exactly the same is true of memantine. So unfortunately, whatever people tell you, the trial evidence is that the dementia drugs are not a good treatment for the sort of non-cognitive symptoms that we see, certainly in people with Alzheimer's disease. But if you've got Alzheimer's disease and you've got a real psychosis, so you've got real delusions and not just behaving a bit badly. So if you've got a delusion, if you think, for example, that your husband's been replaced by an imposter, or that you don't recognise your house as your own, or you think your daughter has stolen your bus pass, there's lots and lots of evidence that an antipsychotic is better than placebo. And here's some of that evidence. So this is a clever study, it's a withdrawal study. And in this study, what happened was people who had Alzheimer's disease and had a delusion were treated with an antipsychotic until that delusion had gone away. And then they were randomised to either carry on with the antipsychotic or to come off it and get placebo. But the tablets looked exactly the same, so they and their doctors didn't know what they were getting. And then the patients were followed, and they were initially followed, so the top graph shows you what happened in the first 16 weeks. And on the y-axis, we've got the proportion of patients who actually had relapsed, who become psychotic again. And you can see in the first 16 weeks, more people who were randomised to get placebo, so who came off antipsychotic, became psychotic again. And then fiendishly, they took the people who'd been kept on risperidone in the first half of the study, and they split them in half again. And this time half got risperidone and half got placebo. And again, they saw exactly the same effect in the second half of the study, that even at that later time, so week 16 to 32, more people who were randomised to get placebo, who came off their antipsychotic, became psychotic again. That's very convincing evidence for me that if I see a patient who is deluded or hallucinating, and I give them an antipsychotic, I expect them to get better, and once they're better, I'd be very reluctant to stop that antipsychotic. And that's very different from seeing a patient who's just got challenging behaviour, or is a bit agitated, and wanting to keep them on an antipsychotic. Totally different. So you were taught this morning, weren't you, about the cholinesterase inhibitors? Were you told what happens when they're stopped? So when these drugs first came out, they were very expensive, weren't they? And the villains in that were the drug companies, who just made them ridiculously expensive for what they did. Stupid. And unsurprisingly, NICE got involved and said that the drugs weren't cost effective. And they certainly weren't cost effective in people who had severe dementia. But they said that on the basis of no evidence, and no one had ever really done a trial looking at what happened in people who had severe dementia. So we did a trial, it's called the Domino trial, and in that trial we took people with Alzheimer's disease who'd been treated with donepezil in a memory service, but because these drugs don't actually stop the decline in Alzheimer's disease, their condition had deteriorated to the point where they were at sort of the moderate to severe point of their dementia. And that would be the point where NICE initially had said these drugs should be withdrawn. And we looked to see what would happen if you, at that point, if you did withdraw the donepezil, or if you continued it, or if you stopped it and gave memantine instead, or if you continued it and gave memantine as well. And essentially what we found was that stopping the drugs was a really bad thing. A really bad thing. The patients who were randomized to come off donepezil, all their memory functions and their activities of daily living kind of functions deteriorated much more quickly in the following 12 months than the patients who were allowed to stay on. So the message from the trial was don't stop these drugs. If you're on these drugs, even if it's quite difficult to take them, carry on taking them because you will be getting benefit even though it looks like things have deteriorated. And interestingly, NICE changed their guidance. It's really important these drugs aren't stopped. And I want to show you a piece of really red-hot research data. It's so red-hot that this morning I returned the proofs to Lancet Neurology of the paper that has this data. Now this paper is embargoed apparently till the 27th of October. But there will be a big news story. The BBC are interested in this, and both the Alzheimer's Society and the Medical Research Council are writing press releases about it. But in that Domino study, we didn't just look at cognition and function. We looked at where patients ended up, what happened to patients who've been in the study. And we followed them for 4 years. And what we were really interested in was trying to find out when did they go into a care home? Where did they reach the point where their families basically handed in the towel and the patients had to go into a care home. Now, what this graph is, it's a survival curve, and what you can see on the y-axis is the probability of being in a nursing home, and along the x-axis is time in months, going up to 48 months, 4 years. And what you can see is at the beginning of the trial, nobody was in a nursing home, and at the end of the trial, about 80% of the patients were in a nursing home. Now, again, only those of you with very good vision will be able to see that there are two lines there. The upper line, the red line, shows the patients who stopped donepezil. So they didn't know they stopped donepezil, and the people doing the assessments didn't know they'd stopped. And the blue line shows the patients who continued with donepezil. And at every point in those 4 years, more patients who'd withdrawn than those who carried on were in a care home. And in the first 12 months of the study, if you stayed on donepezil, it halved your risk of going into a care home. The drugs aren't actually stopping the decline in Alzheimer's disease, but what they are doing is they're helping with the activities of daily living. So the patients who stayed on them did much better in terms of being able to sort of dress themselves, feed themselves, do those kind of those ADLs. And it was the support of that made the difference, that meant that those patients were less likely to go into a care home. So this is, as you can imagine, it's a very exciting result, because even though it's not a breakthrough, it doesn't represent a new treatment, what it does show is, well, actually, here's something that was hiding in the use of a drug that's generic and cheap. It's gone off patent, so donepezil costs us a few pence a day now. A massive kind of societal and medical gain associated with continuing to use it. So, this is my last slide. I've almost finished. We know very little about the psychiatry of PCA, and I'm sorry about that. I feel guilty and ashamed. But we know a lot about the psychiatry of other dementia diagnoses, and I've only really been able to skim over that this afternoon. But most importantly, we can do a lot to treat the psychiatric and psychological problems that complicate dementia. So, we should be optimistic and positive about the help that we can give and that you and your families can receive when people with dementia encounter these kind of problems. And there's obviously an urgent need to understand more about PCA and to investigate, not just to catalogue the problems that people with PCA have, the sort of mental health difficulties and the sort of psychiatric symptoms, but also to do the kind of trials we've done in Alzheimer's disease to see what treatments work and how we can help. Thank you very much for your patience. Thank you.
Rob, thank you so much. As always, a witty but also very insightful talk, and with one given with real feeling. We're delighted that you're here so that we can do exactly what you're saying, a proper study about psychiatric features in PCA. We've got about 5 minutes or so for some questions, so if I will try and repeat them again as normal. So yeah, please fire away.
Like moderately
So the question was, were people in the Domino trial in late stage Alzheimer's?
So there were patients who had been treated with donepezil from early stages, but had declined to the point where, certainly when we were planning the trial, nice guidance suggested removal. So we're talking about a mini mental state score on average of about 10.
So the question is, for someone with PCA, how might a psychiatrist treat them in a way that was different to a neurologist, or what treatments might be given?
So I think I'd be first of all be much more interested in the kind of peripheral symptoms other than just the cognitive deficits. So I'd be interested in looking for anxiety and mood disorder, evidence of delusions or hallucinations. And then I would go into action in the way that I always do when I see a patient who's got one of those problems. Because I know that in my pocket I've got lots of treatments that will make a difference.
How do we get to see a psychiatrist?
So,
is the question.
So you should. So either your neurologist who you're seeing could make a referral to a psychiatrist, or your GP could refer you to local services.
So I think the question was, how much of the treatment for these sorts of problems is through medication, and how much is it through support mechanisms, perhaps talking therapies and other approaches?
So I think it's about 50-50, because actually sometimes the best treatment for a delusion is just helping everybody to not react to it. So when your mum tells you that you've stolen her bus pass, you don't feel all guilty and burst into tears, and you just change the subject or move things on. The drugs on their own aren't the answer. What the drugs will do is take away some of the salience and emotion around the beliefs, but they may not go altogether. But certainly teaching people what to say when their mum accuses them of something or says something is really important.
So the question is it correct that people will only be seen 5 times within NHS services?
No. And that may be the rule in a particular clinic. So you have to remember, some clinics are quite poorly resourced, they're quite small, there's perhaps more demand for their services than they can manage, and so they have their own ways of rationing what they offer. There's no rule within the NHS people only get seen 5 times. I can think patients that I would see. I remember I had a chap who was chronically very suicidal, who made all the other doctors saw him very, very anxious, and I saw him once a month for 7 years. And in the end he didn't kill himself, he had a stroke. But and he became like a friend, really. And if I was out in my car and I spotted him, I'd give him a lift. So I think the number of times people get seen is driven by their need rather than some unwritten rule.
Okay. Robert, thank you again. It's been for a fantastic talk and really interesting questions, and I hope the beginning of a new conversation here.
Thank you.